Good afternoon, Shweta ma'am. Ma'am, shall we
Good
start?
afternoon. Yeah, good afternoon, Shilpa.
Okay, ma'am. 1 minute. Good afternoon, everyone, and welcome back to the afternoon session. I'm Shilpa, Assistant Professor of ECE GRIT. Would like to welcome you all for the 14th session of FDP on Artificial Intelligence Impacts on Telemedicine. It is my privilege to welcome Dr. N. Shweta, HOD ECE, for her talk on open challenges in 5G in telemedicine. In this regards, I would like to have a small introduction about her. Dr. N. Shweta is currently heading the Department of ECE, GRIT Hyderabad. She obtained her bachelor's, master's, and PhD from JNTU Hyderabad. She has been serving the institute passionately from 15 years in various positions. She convened conferences, FDPs, and workshops in various fields, including artificial intelligence, signal processing, IoT, and cognitive radio networks. Her domain of expertise includes spectrum sensing for cognitive radio networks, sparse modeling for compressed sensing applications, and 5G. She has 17 years of experience in academia and had published over 20 research articles in various journals and conference proceedings. She is a reviewer of KES International Journal and various Springer International Journals and CEC-NET Conference, South Korea. She works actively alongside her mentor, Dr. Samrat El Sabat, Professor of Central University, Hyderabad, and published numerous research articles in prominent journals. Welcome you, ma'am.
Yeah. Thank you, Shilpa, for your introduction. So can I share the screen
Yes,
now?
ma'am, you can share.
Is it okay?
Yes, ma'am, okay.
So can I hear from any one of the participants? Good afternoon, one and all. Any one of you, can you see the screen?
Yes, ma'am.
Yeah, thank you. So
Yes,
today's small lecture on 5G in telemedicine open challenges. So I would like to introduce about 5G networks and their impact on spectral efficiency and the impact on healthcare. So I have done so far a small research on using 5G candidate for my cognitive radio networks application. So I would like to even share that. So coming to 5G, so people think that when I talk about 5G or when we hear about 5G networks, people think that it is large internet. So I think when we talk about next generation of networks, most of the people simply mean 5G as faster internet. But if you see healthcare applications especially would benefit greatly from such reliable connectivity for the medical devices and massive objects with large bandwidth. So then when compared to 4G LTE, so already we know that 4G LTE has already given good bandwidth, but when we compare with that, the seamless communication and higher reliable connectivity is available from 5G. And if you think about any virtual reality, augmented reality, all will be greatly benefited from 5G, with actually the main potential contribution to the intelligent medicine. And when we talk about the present, what about the present and future networks? Future networks. So in that, how the 5G networks have an influence, why we are going for 5G. So if you see the radio frequency bands of 5G, 5G NR means 5G new radio. So according to the new radio standards, you can see that below 6 gigahertz is called as actually sub 6 gigahertz technology. We call it a sub 6 gigahertz. That means it is the radio frequencies of these network bands will be less than 6 gigahertz. Especially these are mid and low frequencies which are used for rural areas. So you know that if you talk about 5G, that is greater range, that is above such a range of communication may not be available. That is, the complex hardware may not be available in rural areas. So that is the reason why sub 6 gigahertz can provide higher internet connectivity in rural areas. Whereas greater than 24 gigahertz, if you see, this is called as millimeter wave technology. That means actually between 26 gigahertz, if you see 24 to 100 gigahertz, that is a range of 5G. So where millimeter wave bands, wave bands can be used. So those are higher than 5G. But when you see actual carriers, they have even rolled out the networks between 26 gigahertz to 39 gigahertz also. So, and even in between that, also we have centimeter wave. That is also one more technology. So coming to 5G, purely 5G can be implemented, and all the advancements of 5G will be available only with millimeter wave technology. But these are ultra fast, not even super fast, ultra fast, large bandwidth, and especially less network congestion. But only limitation with millimeter wave is short range. Short range, that is the reason why more antennas ought to be deployed in the region. You need more antennas, more complex hardware, more towers for coverage. So it is expensive to deploy. So that is the reason why dense urban areas where massive MIMO can be functioned. So in such areas, millimeter wave technology can be used. And when you think about why we are actually opting for 5G, because of you need faster reliability. So especially with the advent of Internet of Things, you can see that there is lot of device capturing the data, and then it is transmitting to the receivers. So with that explosion, you need the networks which can have different architectures. So actually these, when you talk about these networks and devices, they'll have completely different radio access technology, different architectures and different algorithms. So everything, it is to be changed. And one more is enhanced mobile broadband. So the broadband and enhanced mobile broadband, it is called as, so that is for higher capacity. So all these HD videos, all that can be provided with enhanced broadband. And whatever I told you, it is ultra fast. How is that? So it is low latency. So low latency in the sense, the response time is low between the data packet which is being transmitted and then received. The latency is very low, provided by 5G. And massive machine type communication. So massive MIMO. So actually when I talk about massive MIMO, adaptable beamforming and miniaturization of complex antenna processing functions. That is your industry 4.0 revolution. So all these mixed is your 5G new radio network. So you need all the complex hardware. So if you talk about the present networks, I think you can identify all these are called as, anyone of you can tell me what are these? Cells, macro cells. So we call it as all these are macro cells, and each macro cell, you have a base station. You have an antenna which is controlling. So this will provide you the complete coverage. So that's why your total area was divided into different regions, and they are called as macro cells. So when you compare with when you compare it with the networks, you can observe that the spectrum is very rarely, that is very insufficient in the case of especially for unlicensed. So you know that there are many licensed bands and very few unlicensed bands. So I think you heard about industrial, scientific and medicinal band and UNIA bands. Those two are free bands which are operating at 2.4 gigahertz and 5.4 gigahertz. 2.4 gigahertz, you have I think 14 channels, ISM channels you have that can be used freely for your Wi-Fi, Bluetooth and urban applications. So those things can be using, but those, if you see, they are overcrowded. Whereas if you see the licensed bands, they are not fully efficiently used. So in some regions, they are not used at all. And the survey says clearly that only 30% of the licensed bands are fully utilized. So that was actually the gap which is used and which can be dynamically accessed, and that can be used for communication. That is the future. And if you see the complete picture, you can see that these are nothing but small cells. These are nothing but the small cells, you can see. So why do we go for small cells? Is to improve the capacity, to improve the coverage, we go for dense small cells. Even I think in literature, you can see there are many people who are working for improving the capacity using femtocells, picocells, and microcells. So these small cells are nothing but radio access nodes. These are radio access nodes that operate both in licensed as well as unlicensed spectrum, and they'll provide a coverage of some 10 meters to some few kilometers. So this will improve the coverage. So these are the small cells. So if you see in the future networks, if you see here, there will be a balance between licensed and unlicensed spectrum. So you have observed that unlicensed spectrum is more used, whereas licensed is very sparsely used. So if you have a balance between those, then all connections can be provided with good bandwidth. So greater capacity can be achieved. So you can see that here there are many small cells, isn't it? So, but these oval or nothing but Wi-Fi. Wi-Fi can also even improve the capacity, but only till certain range. But whereas the small cells, it can improve the capacity. So you have many small cells to improve the coverage. And advanced radio methods. Advanced radio methods. If I talk about MIMO, you have smart antennas, short range, multiple antennas. And you can say unlicensed, whatever I have told you, and sharing of spectrum. So especially this was not possible because the government has some limited sharing of spectrum, and it has laid some conditions to use the licensed spectrum. So that is another area again. So that permission, if it is being given, then we could have reached higher spectrum speeds by this 21 itself. But from 20, some of the countries are actually going for 5G, but for limited applications. So if you see, when you compare it with the present and future, there is a wide jump to improve the capacity. So especially this can be captured by healthcare. So there should be a separate spectrum only for healthcare applications, only for telemetry applications. So if you see, the research clearly says that this is the band what we are talking about. So if you see this particular band, that is below 6 gigahertz, you can see below 6 gigahertz, if you see, the type of duplexing is frequency division duplexing. So and here all the cell sizes are macro cells. I think you know about frequency division duplexing, where uplink and downlink, they use different frequencies and they're separated with guard bands. Whereas if you take centimeter wave, you have small cells. But when you take millimeter wave, that is in the range of 5G, there you can see that time division duplexing is used. So that means you have only a single frequency, isn't it? You have single frequency both for uplink and downlink, but they're separated by guard bands. But here you can see that the cell size is ultra dense. So you can see ultra dense, more small cells are being deployed, more and more. Okay, and these are some of the specifications of 5G. Latency is less than 1 millisecond. And if you see latency end-to-end device to core, it is less than 10 milliseconds. So that can be, see, you can see the speed of your communication now. And you can see there are some other parameters like density, area capacity, and spectrum efficiency is 10 bits per hertz per cell. And the throughput is 10 gigabits per second. And you can see that 90% improvement can be achieved in terms of energy efficiency over the 4G LTE. So some specifications, but coming to the first challenge, what can you start with in 5G is the modulation. So one, I should say I'm only in the first step. So I have successfully completed first step. That is, I have used this 5G UFMC signal for my communication. So if you see 5G, what type of modulation will give you good spectral efficiency. That is important to be considered. So OFDM can be used, SCMA can be used, and filtered OFDM versions are there. Filtered OFDM can be used. I think you all heard about orthogonal frequency division multiplexing, where you have multi-carrier. This is a type of, this was the first introduction about multi-carrier modulation. And the more another version of OFDM is the filter bank multi-carrier. This was introduced. Why? Because I think almost a few years, the research has been going on to reduce the peak to average power ratio of OFDM. You can see that this is actually the average power of the signal, whereas the peak power is this. So this ratio, peak power, average power to peak power ratio was very high in the case of OFDM. That was reduced in the modification of OFDM A and filtered OFDM. And finally, people have given filtered bank multi-carrier. So the same QAM modulation is used, same data is divided into frames, and then symbol mapping, QAM processing, the frequency spreading, and then going for IFFT and passing it through the, inserting the cyclic prefixes and passing through the channel. That is the same thing. So the modulation doesn't change. Only thing is in OFDM, in FBMC especially, you can see that a filter is used for each subcarrier. If you take OFDM, you have a filter at the end before passing it through the channel. Whereas in the case of filter bank multi-carrier, you have a filter for each subcarrier. Whereas in the case of universal UFMC, universal filter multi-bank carrier, instead of, see, because for each subcarrier, giving filter for each subcarrier, it was looking complex. So what they have done is group of subcarriers is actually called as a subband, and a filter is used for each subband in the case of UFMC. So these are the key 5G technologies. So if you want to start using the 5G candidate, then you can go for any one of this modulation technique, and you can transmit your data and you can check the spectrum efficiency. That is the first step. Okay, so this is about what type of modulation can be used in 5G. Okay, so these are my results about the 5G signal. So what my research area is spectrum sensing. So 5G, I have used 5G candidate, and I have compressed this 5G candidate, compressed this signal, and then I have I didn't reconstruct it. With the sparse samples. What I did is I applied some robust techniques like robust median absolute deviation, and I calculated the entropy of it and then compared with the threshold. And I'm just checking whether the 5G compressed signal can be detected at the receiver or not. And if it is so, I have observed that using the robust, I have compared two techniques. One is correlation entropy and another one is Parson entropy. And I have seen that lower SNR, that is minus 8 dB SNR signals, were detected with a false alarm rate less than 0.2. Even minus 11 dB, minus 11 SNR dB signals are also detected. And what I have to, this 2030 is nothing but actually the noise variance ratio in alpha stable noise. If you take the typical non-Gaussian environment, in non-Gaussian environment, alpha stable noise, that is impulsive noise, is very difficult to detect. So, and that too with a very high noise variance ratio. This is 2030 is actually very high noise variance ratio. So even with high noise variance ratio, my method was able to detect the signals at low SNRs. So that has been proven the efficiency of 5G, that too compressed 5G signal. So that is the efficient. When you compare it with any other DVB-T or a QPSK or a QAM direct modulation signals, if you compare these, the same performance, if you see, with even with a noisy environment in the channel, you can rightly detect it because of its improved efficiency. So that is, I thought it will be a good insight. And coming to the peak data rates. So the peak data rates 1 gigabits per second has been improved to 50 gigabits per second. So if using this new bands, newer NR, new radio bands, the peak data rate has been increased from 1 to 50. So coming to the healthcare, how 5G capabilities will actually impact the healthcare applications. So one is you can see the research and the people, the vice president, the research and CEO of health technology company, these are their comments. I thought it will be useful. Healthcare monitoring will generate huge amounts of data because of lot of IoT devices. So lot of data gain. And people said that 4G cannot provide reliability of, even though it has sufficient data rate, but it cannot provide reliability of connection because you need high definition videos to be transmitted. The patient, the diagnosis, and then the treatment. For example, MRA reports, scan reports, they need very high resolution. So such image files are to be transmitted in no less time. So that is one comment. And another one is UK Council Manager increases in bandwidth enables key high definition video streaming use cases. So high definition video streaming, it is to be done. That for that you need high bandwidth. So bandwidth at the rate of 100 megabits per second on average. And Wi-Fi is also not fast and even not secure or reliable because it may sometimes there will be a connection and sometimes there will be no connection. So that is another comment. So based on all these comments from healthcare people, so they have decided for improving the capability of telemetry, the latency should be under, that is less than 110 milliseconds. So low latency, what it can bring, low latency can bring data and video, and so that can be sent in real time to hospitals, especially in emergency situations. And high bandwidth, why do you need high bandwidth? Whatever the high definition video and audio files, they can be transmitted, and it will enable video to be streamed live. Especially live streaming can be done without any loss of quality or without any buffering. If it starts, but if you use any 4G connection, if it starts buffering and then the time it takes to respond, if it is very high, then it is very difficult. So especially in the case of emergency respondent body cams will be there. So it cannot be given live for more time. And next is one more thing is capacity is okay. So it should give you a higher capacity and reliability. So network reliability is one more important thing with security. Security is also one more given. So that 99% network reliability is provided. And emergency services, especially, they can have own private slice of network. So due to 5G, especially in UK, they have a 5G separate band for telemetry. Even we also have it, but in 5G, they have given a separate band and separate allocation for only for emergency applications. So this is the capability, how it is provided. All these characteristics are very, very important in the case of the healthcare. And battery life also, it can be up to 10 years battery life, especially for low IoT devices. The first case I just want to tell you, so I have just listed some 8 to 10 cases of remote healthcare. Connected ambulance. So if there is a connected ambulance, and you can see what is the sophisticated hardware and the technology which is available inside the ambulance. It is looking like an ICU, isn't it? So this is the sophisticated ambulance. So doctors can receive diagnostic information from this scene before the patient arrives to the hospital. So what happens is this will optimize the treatment time. And especially the people who take the patients from the ambulance, that is those they are called as paramedics. Yes, paramedics, they are trained people who can stabilize and prepare to be treated in the hospitals. So they can instantly review the patient's healthcare history, and by actually wearing AR glasses, especially they'll have AR glasses, and using AR glasses, so they can review the patient. So but the trained people should be available in the ambulance. So before the patient arrives the hospital, especially in emergency situations, the connected ambulance will actually help the staff, help the patients. So because the hospital knows which type of patient is coming, and during the journey itself, the paramedics will be able to send the 360 degrees images, vital signs in real time. So this will reduce the lag time. So, and you can see directly high resolution images, and video calls also can be made between the hospital staff and the ambulance, so that the doctors will have a better understanding of the emergency. So that is one basic area using 5G. And next is high definition virtual consultation. So this we have already started because of this COVID pandemic. You can see that the remote HD video, high definition video, two-way, it is actually used between the patient and the professional doctor to conduct initial screening assessments, routine health checkups, and rehabilitation sessions, visual diagnosis. So everything can be done remotely. So due to which what happens, so you can see that the travel time and the consultation cost can be also reduced. So if you see, you have the database management system. So in that, completely the information can be recorded, and you can see that you have the patient stays for very less time in the hospital, and the doctors can treat more patients, and the throughput can be more, decreased waiting time. So you can have on total healthier population. So this is the main motto of 5G impact. And remote patient monitoring. So this is also whatever we have just discussed about. So with virtual consultations, so the patient can be monitored. And one more is the main important, that especially for old aged people, is medical adherence. So there is a lot of research is actually going on to provide medical adherence. Why? Because see, for example, normally even not even old aged, even the young people also, they do forget to have their medicines, and they lie with the doctors. So that is one problem. So adherence to prescription, especially, this is a key challenge in healthcare industry, especially with some elderly and even mentally ill patients. When they take the medication, they don't take it properly. So here 5G can tackle it with video enabled medical adherence. So video enabled medical adherence is provided with a gadget. This is actually provided by the UK internet enabled MediHub. This is called as this was developed by Palman company. So Palman has actually developed a test bed using 5G test bed. They have provided a device which is actually a remote monitoring system that will allow the pharmacists and technicians to observe patients. So how is it? See, for example, so you can see that you just have a switch. You can connect it, you can switch it on. You can see that you have audio and video capability for this. So this is a power button. So once every moment, for example, the patient has to be given medicine 2 or 3 times. So those 2 or 3 times, the professional care will call him, will ring him up, and then he'll watch him up, and he'll say what medicine you are taking. I think I can even show you that here. Yeah, so this is one device, Palman device. So you can see this is the power button, and you have a video. This is video, and then this is audio. So the patient is just sitting in front of it, and he's showing his prescription. So she's showing the ointment name, the drug to be used, and the pharmacists and the professional carers directly will interact with the patient. You can see this, and you can see there are 3 screens here. One is to record, what type of medicine, how much it is taken, and which part of the body it starts, ideally speaking, which part of the body it is affected, and what should start healing after taking that much dosage. So that is called as, actually these are called as medical administrative records, MERs. So this was also developed, and which will give you correct precipitation and dosage so that it is taken at right time. So this is, I'll show you those three screens more close up. You can see this is actually the MAR charts where the carers will record everything. How much dosage is taken, at what time it is taken, everything is recorded here. So that is one advanced technology which is actually making which is helping the patients. And there is one more which will come in future, 5G enabled remote surgery support. So taking the experts' help. So quickly using 5G, larger image files can be transmitted. So you can see this is a 4K display. So a small, you can see small surgical microscope can be inserted into the body, and using a high definition display, the complete operated area can be observed by the expert. So with the help of expert, people can be guided, and high quality surgeries can be taken care. And one more is improved patient experience. So you can see you have the actual doctors and also the experts. So experts can also give a suggestion, as well as the information can be recorded by the doctors, and you have more reliability. So that is reliable real-time remote monitoring. So using 5G enabled. And AR and VR, you can see augmented and virtual reality connections. So you can see that in hospital, surgeon wears handset with video feed. So he's wearing a headset with video feed, and using high streaming connection, you can see that the it is transmitted, and the remote specialist receives high quality video information to VR headset. So this is AR headset and this is a VR headset, so that the surgeon gives some suggestions. So this is one area. And coming to the use cases. So if we talk about the use case categories in healthcare, the first use case category, that is where AI can be applied, is patient applications. So you can see that the complete data is available in the records. So, and one more thing is, in some of the hospitals, they don't share those reports. Actually, to be frank, they should not be shared to the patients. So they are recorded, and when for a second suggestion or for a third suggestion, they can be transported to another hospital, that's all. So those applications can be recorded using that, the precise medicine, prescription, so precise medicine can be given. So that is the precision medicine. So that is one more area where, without past research, without knowing the past status of the patient, without analyzing, it is difficult to start giving the accurate medicine. So because of increasing number of fields like even immunology, psychiatry, respiratory disorders, oncology, you can see that there is a lot of big end, if you see that big data analytics, back-end big data analytics, there will be a lot of such type of back-end data analytics to be done using AI methods. So what it does is, using the individual characteristics of the patient's genetics, some specific disorders can be identified. So that is one use case. And another use case is hospital applications. So quickly, the records are to be transmitted. All the medical image files, like your scan reports, MRI image files, they are very large, and those files are to be shared to specialists for review. So through the and they can be used even for the administrative and medical purposes. And telemetry. So one more is telemetry is telecommunications for monitoring. So with 5G, especially with millimeter wave capability, 100 megabits per second concurrent telemetry links can be supported using millimeter wave technology. And if you see that the medical data management, you can see that for each disease, all possible data sets can be collected, and they can be made available for analysis. So that is one use case. And another is the printing, ambulance drones, so which will actually facilitate the patients as well as the doctors. So these are different use cases where AI can be applied. One is you can talk, but a lot of research is actually going on precision medicine. So take such type of data sets. So if you want, you can just take a screenshot also for this. So these use cases, people are taking those medical, some of them are working with disease diagnosis, and some of them are working with applications, monitoring, and for telemetry or whatever it can be. The prerequisites will be these records. One is data management, one is for medicine, and another is for MER disease diagnosis. People have done a lot of research is already available, but I think we can concentrate even on precision medicine also. And so this is how the 5G is actually reconstructing the healthcare. So because of higher data rates and very low latency, even less than 1 millisecond, and higher bandwidth. So these three are the three edges which is actually benefiting the healthcare applications. And the impact is all the types of 5G is actually providing all these services. One is sensor in first of all is nothing but the sensor innovation. Because of IoT, you can see that there are many sensors, innovations in medical devices. They are providing many more medical gadgets. For example, sensors that will fit into your palm with many sensors in it, that will help doctors to provide a complete health picture for their patients. So this will lead to a personalized health treatment program. So this will know the complete status of the patient. And coming to the AR and VR technology, if you see, the virtual reality and augmented reality, they are directly benefited. And here, for example, you can see that robotic support. I think I have a video also for that. Rehabilitation exercises, robotic support, even for fine motor skills of limb activity. So all these can be supported by VR. So why? Because, and one more thing is VR needs very low latency. So that is actually provided by the next generation. Is it can, the response time should be very less. The response time between the data request and the terminal device and receiving the data. So 5G offers 10-fold decrease in latency when compared to 4G. And transportation is one is, and smart hospital care, and also the diagnosis through AI. So all these are directly impacted from 5G. And you can see this is a small use case here. So in level one, these are the 3 levels with the this is actually proposed 5G IoT architecture. This is actually taken from one 5G telemedicine systems. So this is proposed 5G IoT architecture, which can assist medical professionals to monitor remote patients through these sensors through specific devices. In remote monitoring, you can see that there are many wearable devices and the mobile devices, smartphones. All these are called a sensor layer. This is actually called a sensor layer, which is responsible for collecting the data. So here you can see this is level 1. So in level 1, you can see that this is actually called as a primary healthcare unit. So in primary healthcare units, the users can use mobile devices or using webcams or using the body sensors, all give data that is communicate using small base station. SBS is here small base station communication. So using small base station communication, they'll communicate to the layer which is called as IoT gateway. So they're communicating here using IoT gateway. This is actually called as a network layer. IoT gateway here is called as the network layer. And from there it is communicated to the communication layer that is using 5G, this is called as major base station. So major base station is connected using 5G. And from here, the data will be transmitted to the medical services. So how was it transmitted? It is actually transmitted to the local hospital through this. These are actually the records, electronic health record system, and also cloud storage. So cloud storage, so the data is transmitted to the emergency health records and also to the cloud storage. And from there, the hospitals and the specialty center is given authorized access. So the authorized medical professionals in the main hospital and also in the specialty center, if needed, they can access all the medical servers to monitor the patient. So if for example, in the case of a rare disease, then the specialty center will analyze the data using some diagnostic information, and then the decision is taken. So this is one complete 5G IoT architecture which is proposed in 5G telemedicine systems. And I have a small video using 5G. So let me play this. Robotics. Can you hear this?
Increase the volume.
Increase
the volume.
One expert, like a medical doctor, is wearing a glove that can use in order to examine someone remotely. The doctor is now controlling a robotic arm and
Not audible.
pick up what they are touching. Those signals are sent to the first solution into process tactile gloves. So you can actually
so you can see this is the gloves. So 360 degrees video can be provided. So you can see this is the VR capabilities, AR VR capabilities.
medical appliances, but legal appliances that are needed to enable these kind of use cases.
So you have robotic arms, haptics to sense. So you can see his sensing now. Yes. So this is Ericsson has been using it, and they have started for providing surgical robotics. So this is one sense, and also Palm, I thought I'll do, but that was security issue. We cannot even post that link, and it's not available in YouTube. You can refer to Palm also. Either medical authorization reports we can work on, or you can see the gadgets developed by Liverpool, actually Liverpool company of UK. They have developed these gadgets. So that's all from my end. So these are some of the challenges what I have discussed. Hope you understood, and if you have any doubts, you can ask me now.
Yeah, it's open for discussion. Any doubts, participants can ask.
So let me show you this Palm. So this was the gadget what I'm talking about. So this was the gadget what I was talking about. So this is the health records which can be monitored. The internet and so whatever the company names, Liverpool 5G test bed. So this was actually the test bed with which they have implemented. So you can see the power button, and it was very user friendly, especially for the elder people. So they have given a small video also here. I think you can see this. Can you see this, Shilpa? Is it visible?
Yes, ma'am. Yes, ma'am.
Audio? I think audio is
Audio
not.
is not.
Now also.
Morning, Joan.
How are you today?
Fine, thank you. Kezzy, you?
I'm good, thank you. So have you got your blister pack there with your tablets in?
See how you can see this. She's
Oh,
showing the
wonderful.
prescription.
So yeah, if you just hold that up for us, that's great. I can see your prescriptions on there and I can see your tablets for today. That's lovely. So when you're ready, if you could take your tablets.
So before the person, before the caretaker, she's taking the medicine. And now she'll record it in the chat.
Wonderful. That's great, Joan. So you've taken those. And
See, she's
your mark
recording.
is all up to date today.
Thank you.
And then I'll save all the information there for you. And your next call is at 5 o'clock today.
Oh, thank you so much, Kezzy.
You're more than welcome, Joan. Have a lovely day.
Thank you for calling.
Bye
Bye.
now.
Bye.
Bye.
So, yeah. So if you have any doubts, yeah, anything if you want to share, you can share now.
It seems no doubts, ma'am. Everything is clear, I think.
Oh,
Thank you, ma'am. Thank you for sharing the concepts of 5G and of what are the challenges in 5G and how they are integrated in the telemedicine and everything, ma'am. Your presentation really optimized everything. Thank you, ma'am, for taking your time to prepare for such a wonderful presentation.
Thank you.
Thank you. Joseph, sir?
Yes, ma'am, I'm here.
Yes, sir. Sir, we will start, sir. 1 minute.
No problem. Take your time, ma'am.
షేర్ స్క్రీన్ చేసిన తర్వాత
Yeah. Okay, sir. This is the immediate session after ma'am's talk. So this is the last session, 15th session. Now I would like to welcome Dr. Joseph Benjamin. Let me have small introduction about sir. Dr. Joseph Benjamin Gandhi completed MBBS in the year 1987 from CMC, Vellore, and MD in radiotherapy from Christian Medical College, Ludhiana in the year 1996. He was clinical attaché in Jan 92 to December 92 at Department of Medicine and Cardiology, South Shield District Hospital, South Tyneside, UK. He has worked as senior resident CMC Ludhiana and also at NIMS Hyderabad. He has served as assistant professor in various institutions in Hyderabad. He received Dr. Frank Neal Fellowship, Association of Radiation Oncologists of India, to receive advanced training in the field of radiation oncology at Tata Memorial Hospital, Mumbai, India in 1996, and received Rashtriya Ratan Award by International Study Circle, New Delhi at the seminar on role of medical professionals towards society on 22nd May 2006 in New Delhi. He is Life Member Association of Radiation Oncologists of India, BOS member of SVIMS, and Ethical Committee member of ICAR and IIMR. He had guided several MD students and is examiner for MD students in various universities and has published several papers in international journals and conferences. Hearty welcome to you, sir.
Share the screen.
Yeah, thank you. Thank you very much. Thank you very much.
Sir,
I mean,
1
I don't.
minute. I'll give the control now.
Yeah.
Yes, sir.
Enable.
Welcome, sir, and you
Yeah.
can share the screen now.
Yeah, share the screen now. Madam, thank you very much for that nice introduction that you've given about me. I don't deserve such a big one, but I really thank God for the privilege. I mean, God has given me, and especially I thank Anil sir and the Atal FDP for giving me an opportunity to be a part of your program and to speak something on my little experience that I come across in my daily life. And I'm really thankful to you that you gave me a chance to speak this afternoon. So the topic, and I promise you that I will not take much time of yours. I think you've been really taxed by so much of lectures, but I don't think it'll be a big lecture, but something which is my daily observation and my daily experience. And for today's afternoon topic, the topic is an artificial intelligence and telemedicine in cancer diagnosis and management. I want to deal this topic in the following order. I want to talk about definitions in artificial intelligence. Probably you are much better, well versed than me. And it is artificial intelligence improving cancer screening and diagnosis and aid to the genomic characterization of tumors, artificial intelligence in non-invasive techniques to detect brain tumors, accelerating drug discovery and improving cancer surveillance, and finally, the prediction of treatment response. This is a picture which I tried getting it from one of the posters. This is a doctor who's not coming and examining the patient, but he's using all the data that he has in order to get the information from the patient, get a diagnosis and send. You can see him using his headphones, using his laptop in front. You can see him using his cell phone and also X-ray this thing, so that viewing mirror, so that he can come to one diagnosis with all the data that he could get and come to a diagnosis and help the patient who's sitting somewhere remotely and help him out. Now, coming to a little bit of definitions, artificial intelligence is a computer performing tasks commonly associated with human intelligence. Humans are coding or programming a computer to act, reason, and learn. An algorithm is a code that tells the computer how to act, reason, and learn. Machine learning is a type of artificial intelligence that not explicitly programmed to perform a specific task, but can learn itinerarily to make a prediction or a decision. The more data machine learns is exposed, the better it performs. And deep learning is a subset of machine learning that uses artificial neuronal network modeled after how the human brain processes information to learn from huge amounts of data. A well-designed and a well-trained deep learning model is able to perform classification tasks and make predictions with high accuracy, sometimes exceeding human expert level and performance. Now, basically, I wanted to use artificial intelligence in relation to 4 common cancers that I come across. Number 1 is cancer cervix. Number two is cancer of the prostate. Number 3 is something to do with brain tumors. Number 4, I wanted to discuss something to do with breast malignancies and breast tumors. Now, basically artificial intelligence to improve cancer screening and diagnosis. Scientists have applied artificial intelligence to improve cancer screening in cervical, prostate, and breast cancers. National Commission for a National Cancer Institute investigators developed a deep learning approach for the automatic detection of precancerous cervical lesions from digital images. Now, I'm just giving you an MRI picture of the cervix. This is a sagittal view. Both are the sagittal view of an MRI. Now, you must be wondering what is cervix. Now, in layman's term, it is the mouth of the womb or the mouth of the uterus. Okay, it is in the vaginal portion of the human body. It is related to female reproductive system. Now I've showed you an arrow. That arrow shows an early lesion in the posterior lip of the cervix. It has two lips, one anterior lip and posterior lip, and that is a posterior lip of the cervix which is enlarged. You should also know the relationships of how is the cervix related to. Anteriorly, it is related to the bladder, and posteriorly, it is related to the rectum. Now, in the second picture, what you see is, if you have missed on that, and if this disease progresses, what will happen is it will anteriorly invade the bladder and posteriorly invade the rectum. So it becomes a locally advanced disease. So many patients who come in the to present to us will be presenting at the last stage. But you should know very well, this is only a sagittal section that I've shown you in an MRI. But this cervix can be easily visualized through the vagina. When you do a speculum examination, you can easily identify the cervix. Now you look, there is a hole there. That hole is called the external os. The external os opens into the internal os, and that opens into the body of the uterus. Now what happens here? Now, if this cervix is somehow, infected or this thing, you have many common infections here, and most of the infections perpetuate or lead to cancer. Now you look at here. Now, because every person can't come to the hospital, every person can't be examined and evaluated. So what they have done is, they have done a 25-year study in a place called Costa Rica, and they have done this various methods. They have done one method by using a visual appearance of how it looks, two by doing a pap smear, and third thing was automated visual evaluation. Now, when you look initially, what they did, they have colored that area. They have not colored, they've painted that area with something like vinegar. Vinegar is acetic acid. Acetic acid. Now, when you apply the acetic acid, the epithelium or the cells which are abnormal, they take up this discoloration and become white, and it's called acetoacetate or an abnormal white epithelium. Now, when you take biopsies means some small tissue from there and you evaluate under a microscope. When you take a little biopsy from there, it showed early lesions of cancer. The second method they did was, they did a pap smear. Pap smear is using a spatula, you go around the external os and try to take little amount of whatever the necessary material that are there, put it over a slide, and they visualize under the microscope. So, and that can also diagnose an early stage of cancer. But over the period of time, what they have done series of images, and they have taken an images and they have fed the computer so that it will be easy or helpful to diagnose. When they have did a study like this, number one, we can see the visual inspection. Number two, a pap smear. Number three, an automated visual evaluation. When they did this three, all they found was the sensitivity of the visual inspection was 69%, and in pap smear it was 70%, whereas in automated visual evaluation it appeared that it was 90% sensitive, and it was much easier and less task this thing, and it was very, very easy to do. So with all this, we came to know that automated visual evaluation was much easier and much sensitive. Now we come to the next cancer. I told you I will cover a little bit of cervix, next something about a prostate cancer. You must be wondering, what is this gland? How is it? Where is it? Now, this is related to the male reproductive system. Just as cervix is related to female reproductive system, prostate cancer is a cancer which is found in males. Now, when you look at this prostate cancer, it is situated just below the bladder. See, the bladder is the place where your kidneys excrete and it forms urine. It is a chamber which collects the urine and then it passes through the urethra and it comes out. Now, this gland is just placed below the bladder, and the urethra pierces it, and that's how you divide into various lobes. We are not going to the anatomy of it. All that I want to tell you is what happens in prostate cancer. As you grow older, your prostate enlarges. So there are two conditions called benign prostatic hyperplasia, which means the condition is benign, but sometimes this condition can turn malignant. So can turn malignant. I'm just showing the MRI pictures of this prostate gland. Can you see this round? Can you see this round big one which is sitting up there? See, this is a prostate gland which is little bit enlarged. When I magnified it and took a picture of it, can you see this white areas? This white areas here, this side, this white areas here, which shows there's an abnormality there. There's an abnormality there. So this abnormality could be cancerous. Now let's put it this way. Now, in order to do a biopsy is removing a small tissue from that organ, viewing it under a microscope and know whether there is a cancer present or not. Now what happens when you do a prostatic biopsy? Most of them are blind biopsies. It has to go through the rectum. It has to go from the anal canal, rectum, and then take a biopsy. Most of the procedures are blind. So when you're doing a blind procedure, you're not sure whether you're hitting the malignant tissue or whether you're hitting a normal one. So by using this technique, when a computer was fed with so many of these pictures, it was able to diagnose which one is abnormal, and it helped and guided the person who does the biopsy, especially a urologist or a kidney specialist, to take a biopsy. Generally, we do a 6-core biopsy or a 12-core biopsy, which means we need to get so many of this in order to prove in which area the malignancy is present, so that we can treat. So basically, this helped us in managing prostate cancer in a very remote place where people were given such a picture. They were able to diagnose, and from far away, even not a specialist, may not be a urologist, but still he was able to do a little amount of decent work in guiding and getting a biopsy report. Right. Now, when we go to the genomic characterization of tumor, now I want to talk to you about lung cancer. Now, everything that appears as a solid mass in your X-ray may not be, may be a lung cancer. Now, the question is, what type of lung cancer it is? Now, what type of lung cancer is? There are two types of cancer. There are two types of cancer that are there. One is a squamous cell carcinoma, other is an adenocarcinoma. This squamous cell carcinoma is very common in males, and adenocarcinoma is more frequently seen in females. And mostly it's associated with smoking and other habits. And that's the way squamous cell carcinoma occurs. Now, what happened is when a pathology specimens are taken from this tumor, you can identify what type of tumor it is, adenocarcinoma or a squamous cell carcinoma. But when people did a lot of series of sections of this tumor, the people far away with this deep learning technique were able to identify what type of it. The direct learning method accurately distinguished between the two most common lung cancer subtypes, that's adenocarcinoma and squamous carcinoma. So it could predict commonly mutated genes from these images. Now, the question is, what is mutation? Why is it mutated? Now let's put it this way. If it is squamous cell carcinoma, it can be treated in a particular manner. If it's an adenocarcinoma, it can be treated in a particular manner. Now, basically, whether this would only happen if the stages is advanced, when there's a bone secondary, when there's a brain secondary associated with it, and you don't know what type of cancer it is. So there is a gene mutation that happens. That is, one is called AL, the other one is called EGFR. So if EGFR is commonly found in squamous cell carcinoma, and that can be treated by a drug called geftinib. And when you look at this adenocarcinoma, where it's not EGFR, but the other one, it should be treated with crisatinib. Now, when you look at this, when you look at this gene mutation that can be diagnosed, you can tailor make your treatment to to a particular patient. Now, the third thing that I wanted to come to you was something regarding breast cancer. Now, let's take it. Previously, in our country, cancer cervix was very common because our age at marriage, it was early, and there were so many factors to it, and that was very common cancer. Now, in our society, because of education and other better facilities, people don't get married on time. They postpone. After marriage, they postpone their children, and they go for planning. And these are all the problems that we face. And breast cancer has become one of the problems both within the cities as well as in villages too. Now for this, they have done, they worked on an X-ray, which can take, just as a chest X-ray is taken, you can take an X-ray of your breast, and that is called a mammogram. And in a mammogram, they have uniformly standardized it, and this is called a BI-RAD score. BI-RAD means breast imaging, reporting, and database system score. Breast imaging, reporting, and a database score. Now, 1, 2, 3, 4, 5, 6. Okay. Now, 1 and 2, I'm trying to show. Now, what is a feature of malignancy in a mammogram? Now, when you look at breast is a glandular tissue. Inside the glandular tissue, there are tubules. There are tubules or secretory tubules. If you find microcalcification inside the tubule, that will give you an initial diagnosis that it could be breast cancer. Now, over the period of time, many times young girls come and say, sir, please help me whether I'm suffering with the cancer. But generally we assure them, no, not to worry, because generally we don't get in an early age. But when you look at this breast imaging and reporting database, I'm showing you 1, 2, and 3. As you see these pictures, there is a bit of the density of the breast tissue becomes more and more. And in 4, it is the most. And such a one is a suspicious malignancy. So when you have a proper imaging system, a proper data of all these imaging system in a remote place, if such a thing happens, you can compare and you can identify a cancer breast at a very early stage and send it to your referral system. Now, the same thing, what happens is, after the imaging is done, we do a biopsy. We do a biopsy and want to know whether it's malignant or not malignant. Now, I do not know how to pronounce this Russian name, but the other name is Madhubushi Rao et al. They worked on this, and they have done a series of pathology reports in breast cancer. And one thing you should understand, when there is a tumor, you should know there is a proliferation of cells. So when there's a proliferation of cells, there are lot number of nuclei that are present. When there's a lot number of nuclei present, so it appears darkly stained, and you find a lot of conglomeration of cells. When you look at this one, positive and negative, you can see, for our information, it's a very dark slide, and whereas the other one, negative, is quite less stained one, or lighter. So when such a thing was told or given information, this was also able to help in finding out what the pathology is, whether it's positive or negative, and depending upon that, they were able to treat the patient. Now, this is a non-invasive technique to detect brain tumors. Now, the question is, I already told you, there's a last part that I want to deal with. And even this is one of the parts that I want to deal with, was a brain tumor. Now, How does a patient come to the doctor with such symptoms? The general patients that the people come is, sir, I'm having a headache, and this headache is not being relieved with any of the paracetamols. And sometimes they say, sir, I put my finger into the mouth and vomit, and that's how I'm relieved. And next time, sometimes some people may say that I'm getting convulsions or fits, and you do not know what the cause. A man who was perfectly healthy, suddenly having a headache and convulsions will always make you suspect what's wrong with him. So whenever you go to a neurologist or a man who specialized in brain, neurologist or a neurosurgeon, the first thing that he will ask you is either a CT scan or a brain or an MRI scan. Now, these are the pictures of that I'm showing you is MRI scan of the brain. In MRI scan of the brain, now you should know what is the connective tissue that is there. It is something like your neuronal network fibers. There are a lot of neurons that are there, and basically it's called the glial tissue. And whatever that arises from the glial tissue is called a glioma. Now, I've showed you with an arrow mark there's a space occupying lesion which is denser in the middle part of the brain, and that is a mass there. No, this is a mass. Okay, this is the mass. And once you know that there's a mass there, you need to do a biopsy and find out what exactly it is. This is a coronal section and sagittal sections that are there. Now, when you look further, now glioma, I told you, may be benign, may turn to malignant. Now, this is a case of glioblastoma. Now, glioblastoma is these gliomas over a period of time, they change into glioblastoma. Now, glioblastoma is a malignant tumor of the brain. Now, when you look at this glioblastoma, when it was an early stage, you could see most of it was solid. When the first MRI scan was taken, it is somewhere placed in the central, and most of it was solid. Now, when such was taken after a period of 1 month, you can not only see the solid mass, but there's a necrosis, that is blackish discoloration in the center, and there is perilesional halo. There is a perilesional halo. Now, this is a very characteristic feature on an MRI basis, how to diagnose a glioblastoma. If you have a halo around it and a necrosis in the center, you know it is a malignant tumor. When such features, which are very, very characteristic of that of a glioblastoma, are fed, you are able to diagnose it. I wish if the patient came to us in a little early stage like this, because we could at least do something. But when it comes to in a stage where it is necrosed or something which is spread, we will find it difficult, because number one, it's an advanced stage of cancer of the brain, and not only that, it is not a very good histopathology, and the outcomes are very poor. So our question is, if they were a little bit diagnosed early, it would have been in a much better way. Now, coming to gene mutations, I promise you I'll not take much time of yours. In gene mutations, the way to make you understand is, your color of the hair is black, some other person is blonde, your pupil color is blue and somebody is black or gray, and your color of skin is brown and somebody is fair. Now, why are all these characteristics? Basically, it is because of the gene. And when you look at this, there are base pairs of adenyl thymine guanine cytosine. They are arranged in a particular manner and in a particular way. Now, when you do a gene mapping, it takes number of days for a normal human being to do this mapping. Now, when you take a material from a normal person and from a diseased person and do map, and you find what are the genes that are missing, then you come to a conclusion that, okay, because this gene was expressed or this gene was absent, okay, this condition is present. So in order to reduce the time for a normal human being to do, computers did a great job, because it was not only able to get the data in toto, but also able to predict what genes are missing and how this would present in future, and how often a particular gene is expressed in malignant condition, and compare the same to a sample of normal gene. Now, accelerating drug discovery. Well, you know very well, a drug will bind with a protein molecule, and then that's how it acts. Now, by using this data, many scientists have worked and saw how this drug can be delivered accurately to the best way in a better dose, and that's how they worked on it. So artificial intelligence is being used to detect and interpret features of target molecules. I gave you an example, sir. In a lung cancer, if it is a squamous cell carcinoma, it is EGFR positive. If it is an adenocarcinoma, I told you it is ALK positive. If EGFR positive, I give geftinib. Geftinib is a targeted molecule which hits the so and so, and that's how it prevents the cancer from going. The same thing with crizotinib. The reason is it is attached to this molecule, it stops, and that's how it works. So by doing research, there are new molecules. Nowadays, cancer management has become a tailor-made. It's not generally uniform, but we have come to the section of targeted therapy. Now, accelerating the drug delivery. Now, I just wanted to just give you a little bit idea of how this thing happens. Now, cell has two components. One is an extracellular component. One is an intracellular component. Intracellular component, there is a nucleus and a cytoplasm. Extracellular complement, there is a growth factor. Now, let us tell you, what is a stimulus for a tumor? I mean, what is the basis of a cancer? A cancer is proliferation of cells which does not perform a proper function, but it grows at the expense of other cells, which means there is a lot of proliferation of cells which are not properly used. And that is the reason there is a proliferation, and that's why you call it as tumor to tumor. Now, just give you one example of it. To have a 1 centimeter diameter of tumor, you need to have 10 to the power of 10 cells, 10 to the power of 10 cells, which means 10 into 10 into 10, 10 times 10. Okay, just have 1 centimeter. Now we have such tumors which are kgs and kgs. You should understand how many millions or trillions of cells or whatever it is. Now, when you look at this extracellular component, there is a growth factor on top. And when you look on the membrane, this is an EGFR, this thing. No, just go back. Leave it. The EGFR and the growth factor, they both combine together and they start off activate this RAS system. This RAS will go tell the nucleus, which is inside the cell, stating that you have to divide, you have to divide, you have to divide. Okay. So, but there can be some circumstances where there can be no RAS system, but there cannot be an EGFR system which is trying to stimulate the membrane outside, but there can be a mutation of this RAS to KRAS, which is telling the cell to divide. And that's how you have this KRAS system. So by a group of scientists who have done an extensive research on this KRAS have found a drug which can block this KRAS and prevent the cell or prevent the nucleus from dividing. That is one of the and for that you needed a lot of data which was helped by the help of the computer in order to come to a definitive conclusion. Now, improving cancer surveillance. Whenever there's a cancer, number one, you want to diagnose it. It's early stage or late stage, whatever it is. Now, next you're going to treat it. Now, when you're going to treat it, you have a choice of treatment, whether you're going for surgery, whether going for radiotherapy, whether going for chemotherapy, or where all three modalities of treatment is used. Now, number four, once you treat the patient, you want to see what is the response. How has the patient responded to your treatment? Number four, how many years did the patient survive? The question is, many times there is a biology of this cancer which tells you, because of the biology and the nature of the disease, he may live this much. But when you try to alter a biology to a certain extent, you may have increased the lifespan or the life of the patient. So in such an event, the National Cancer Institute, along with the Department of Energy Collaboration, had done a SEER data. SEER data is something like ICMR that we have in our country, ICMR data. It has all the data of a particular cancer. If you're working on a breast cancer, it will tell you at what age the people got it, and whether females were more common than the males, and certain other data, whether the family history was involved, whether sisters of the patient were involved, whether mother's patient, whether the aunt was involved, the mother side was how much was involved, all these data you get it. So putting that into effort as a part of this effort, the deep learning algorithm was developed to extract tumor features automatically from pathology reports, saving thousands of hours of manual processing time. And the goal of the project is to transform cancer care by applying capabilities to population-based cancer data in real time. This will help us better understand how the new diagnostic methods, treatment, and other factors affect the patient's outcome. The real-time data analysis will also allow for newly developed individuals to be linked with the clinical trials and benefit them. Now, the question is, this is the same thing I've covered in the previous thing. We are worried, what is the treatment response? Now, when you look at the cancer treatment response, it takes a long time to see what the response is. Now, just to give you a little example of it, we were worried about COVID and we were worried about COVID-19. And over the period of time, there were so many mutations that took place. And everybody, the research did work. The researchers did work on it. This is so and so. How many days it's going to die? Or how did the patient respond to it? You know, what next happened? Next happened. So that was an early data. But in a case of cancer, you need a longer duration, and that will help you how a particular cancer is going to respond to particular treatment, and how much is a survival, and if it fails, where is a common area of failure. Now, the improvement that is required is in now assessing quality cancer data. The lack of large publicly available, well-annotated cancer data sets have been significantly barrier for artificial intelligence research and algorithm development. Now, the question is data. In the next slide, I'll show you how the data can vary. Because if you have a particular data, the data can be something for an American, something for an Indian, something for people living in Africa and Southeast Asia. So if you have this different data and not standardize it, for some it's going to work, for some it's not going to work, and this data can not be a proper one. Now, this is just generally a picture that I've shown you, like, I mean, Americans, the Africans, and the people living in Africa and Southeast Asia, etc. All these people's database, if it is not uniform and it is not applicable for the entire human population, then I mean, it will not be a good one. Now, how do you improve the data? What is the characteristics that needed? You should have a complete data. Second thing, the data should be accurate. Number three, it should be available at time whenever it's required. And second thing is, it should be accessible. And number four, it should be consistent. So these are the basic five factors that you need. One is completeness. Second is accuracy, timeliness, accessibility, and consistency. Now, what is the improvement required? Now, black box, this thing. Now, suppose I feed a computer consistently with certain data, and when similar picture is given, it gives you an answer, yes, this. Now, there is no way the computer is able to analyze why did it come. Suppose if you give it to your human brain, he says, sir, this drug works, goes first here, it gets metabolized in this point, and then further it gets transferred into this, and it goes into this substrate and works on the membrane, and that's how you're going to get this result. But in a computer, it's going to be straight. You feed the data, you get an answer. And for example, a direct learn algorithm that predicts the optimal treatment for a patient does not provide the reasoning to be used to make the prediction. Making these algorithms transparent could help researchers identify new biological features relevant to the diagnosis and treatment. Now, the question is, how can you improve this? Now, the second thing that you need to address is bias. Suppose a certain person works in certain area. I mean, he has certain bias. Probably if his friends are smokers, he will still think that they're non-smokers and the data can be biased. That data can be biased. So the bias in data can be used. I mean, the bias should help you to develop a proper model which is uniform and the bias is very much reduced. And you have to adopt practices to address if there's any bias. I mean, if you continue to go do a mistake, then the whole data collection itself can be wrong. And we should have the capability to monitor those biases, at the same time monitor performances and applicability of AI models, which means a human should be able to monitor a computer to see whether it's performing well or not, than just leave it alone. This is a picture I've given you, that somebody may be biased to an old person, somebody may be biased to a strong person, somebody may be biased to an optimistic person, somebody may be biased for a certain religion and certain way of food, and etc. etc. So this bias should be should be spoken of or should be addressed. Now, what are the takeaway points in this? Now, artificial intelligence is used as a diagnostic tool. It can be used as a diagnostic tool. It optimizes the schedules of patients and doctors. There's no need if the data is already provided to the doctor before, and it helps to reduce the patient's time because he already knows the history and this thing. So it reduces the patient's time spending with the doctor. And at the same time, it can identify stages of cancer. And finally, it also helps in the drug discovery and drug delivery, and it helps in assessing the effectiveness of chemotherapy in cancer patients. It keeps doctors up to date in clinical research, and finally in data management. These are few of my references. One of the ones which I showed you in red is the ones which I referred to, and I thank you for your patient hearing. I hope I hope I was able to communicate. Thank you very much for this privilege. Once again, thank you all. Thank you.
Thank you, sir.
Thank you, ma'am.
Participants, any queries?
Sir, thank you very much, sir. Joseph, sir.
Thank you.
You are in examination duty also, even though you are spend time and share your knowledge to our participants and also.
Thank you, Anil. You gave me a chance. You gave a doctor a chance amidst the engineer's voice. Thank you very much. I never expected that. Okay.
Thank you, sir.
Thank you very much.
Thank you very much, sir, for sharing all your real-time experiences and what are the different advancements that are used in telemedicine and how to treat them.
Thank you,
ma'am.
ma'am.
Thank you very much, sir, for accepting our request.
Yes, ma'am. If all things become true, you can really manage health very well, ma'am. Thank you very much. Bye-bye. 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 Thank you.
Participants, you can log out now and you can join the valedictory link. In the same link, we will be sharing our exam link also. So please log into that link. I'm ending the meeting now. Please complete the attendance for this session. So both 14 and 15 attendance links are shared in the same link in the chat.